The next presentation will be by Matthew Eagleton on the results and risk factors for SCI following endo surgery.
Thank you. I have my disclosures. Certainly endovascular surgery has brought a change to how we treat a vast number of patients with aortic disease, aortic aneurysms, and aortic dissection. And while we've heard a number of elegant studies looking at the evaluation of spinal cord ischemia following open repair of aortic aneurysms and aortic disease, I can't stand up here and provide you with the same amount of data. It's certainly not nearly as well studied following endovascular surgery as you'll see. So spinal cord ischemia, one of the big questions following endo repair is it the same disease process as seen in open repair? Does it develop at the same rate, for the same reasons? And are current preventive and treatment algorithms applicable to patients undergoing endovascular repair? There are obvious differences between the approaches of fixing these patients that place them at risk. If we look at those patients undergoing endovascular repair, there's no aortic cross-clamp, and this may be beneficial. There's more manipulation within the aorta, which may be detrimental. We don't cool the patient as we might if they're undergoing hypothermic circulatory arrest, or cooling the patient as Dr. Aker just discussed, and that certainly may not be beneficial and may be detrimental. There's potential for slower occlusion of intercostals or lumbar vessels, and we don't know what the role of an endoleak is in helping to prevent spinal cord ischemia, but it may potentially play a role. On the other hand, we're not able to reimplant or preserve any intercostals or lumbars at this time. Even with fenestrated technology, those branches tend to be too small to allow us to incorporate them into a graft, and that may be detrimental in our treatment of patients with endografts. Certainly the thing that they both have in common is the collateral network theory that allows blood supply to continue to get to the spinal cord after and during repair. And we've already discussed the four independent contributors to the spinal cord, which are the left subclavian artery, the intercostal arteries, the lumbar arteries, and the hypogastric arteries, all which are at risk when patients undergo endovascular repair of aortic disease. If we look at EVAR, in EVAR we have two vascular beds that are at risk. We have the lumbar arteries that are at risk and the hypogastric arteries are at risk. And it's a good place to start to look at how much do these contribute to the development of spinal cord ischemia, provided there is continued perfusion of the subclavian in their intercostals. Again, we don't have a lot of data. Probably the largest series comes from the Eurostar database, and the incidence of spinal cord ischemia following endovascular repair of an infrarenal aneurysm is approximately 0.2%. That's pretty darn low.